Hello everyone, this is Mary Gregory with MAS Coding Solution. I want to welcome you all to our YouTube video today. We'll be talking about inpatient coding and just kind of a range of things that goes along with coding. Michael is joining me today. Michael was with me the last time, and you'll probably be seeing Michael, Sean, different people being with me on these videos. So once again, welcome today. Before we get started, I want to clarify something from the last video. In the last video, we was talking about modifier 59 and the new X codes that's going to replace modifier 59. One of those X codes is XU. It's called a non-overlapping service. And I tried to give an example, and I used the example if you had a patient who had 2 ED visits on the same day, that might be an appropriate modifier. Well, I forgot we got a modifier for that. It's modifier 27. Now, a better example, as I was thinking about this, I was like, what would be a good example? Well, I thought about IV infusion and or IV hydration. When especially when that IV infusion and or hydration is given at a different time than a CT scan or an MRI or ultrasound. Whenever someone have a CT scan especially, you're going to have to provide IV hydration. That's just part of it. Let's say your patient is in the emergency room for dehydration, nausea, vomiting, and abdominal pain. And they start IV hydration in the ED. And they decide later that the patient needs a CT scan. Well, when you use the 96360 and you don't put a modifier 59 on it, or soon to be XU, that would be denied because they're going to have an edit that says this hydration is part of the CT scan. And so you would want to use the XU modifier moving forward in 2015 to show that it was a non-overlapping service. So I did want to make that correction. Today we're going to talk a little bit about coding guidelines, be they ICD-9 coding guidelines and or ICD-10 coding guidelines. I'm going to turn this over to Michael and see what he has to say about the guidelines.
Well, thank you, Mary. The easiest and simplest way to think about the guidelines is that's basically your roadmap to coding. Mm-hmm. When you look at the guideline, it's going to tell you you need to code first, and you may have an exclude note, an include note, all kinds of different information in the guidelines. ICD-9, we know by this time next year we're all going to be going crazy with ICD-10. Mm-hmm. The guidelines, they're different, but they're not that different. ICD-10 is going to allow us to code to a higher level of specificity than we've been able to code to in 9. This is a good thing. We just need to make sure that the documentation supports where we're coding, and that's where the guidelines will come into play and help us.
I agree with that, Michael, and I just want to say, as someone, I am a NAHEMA-approved ICD-10 trainer, CM and PCS, and Michael is so right about our guidelines as our roadmap. And a lot of times when we get denial from third-party reviewers, when we get denial from RACs, when we have the OIG looking at us, it's when they give us an error or say you have coded something wrong, they always take you back to the guidelines. And they are a real sticker for the guidelines. So always remember to keep your guidelines handy. Be it whether it's on your phone, on your computer, you got to keep your guidelines handy. And you got to remember to refer to your guidelines. And I agree with Mike as well. We will be able to code to a higher level of specificity. However, like Mike said, some of the guidelines are really not changing. You know, an MI documentation is the same, will be the same in 10 as it is in 9. So we have to have that documentation. And in fact, that'll lead me into what I also want to mention to you all, AHIMA, A-H-I-M-A, and you can go to their website, www.ahima.org, And they have recently given us a clinical documentation improvement tips for ICD-10. And today I just brought a few of them, like when you go into Chapter 1. Chapter 1, ICD-10, that's your infection and parasitic diseases. And they were saying, they gave us some tips like bacteremia. What does bacteremia really mean? Well, see, sometimes physicians use that interchangeably. They say bacteremia, then they say sepsis. Well, they're not the same. See, bacteremia simply means you got some type of positive blood cultures, but it doesn't mean sepsis. So a lot of times when you're coding, you may have to clarify that with the physician. And urosepsis have to be clarified, sepsis have to be clarified. Sometimes the way you want sepsis to be clarified is if they know the organism that is causing the sepsis. Sometimes they will, sometimes they won't. And the rule is the same about sepsis due to some type of graft, some type of implant, some type of device. See, that rule will not change in 10. So if your patient has sepsis due to the fact that they have an indwelling Foley catheter, the complication of the catheter has to go first, and sepsis would go second. And so that rule haven't changed at all. We still going to have severe sepsis. But what is severe sepsis? Severe sepsis usually always includes some type of organ failure. We want physicians to document those organ failures. A lot of times they like to say multiple organ failure. There's no code for multiple organ failure. We have to know each organ that has failed, be it the lung, be it the heart, be it the blood when you have septic shock, be it encephalopathy. The physician really should document each individual one, because you will not be able to code out multiple organ failure. Now, of course, if the physician documents severe sepsis, you can code that out, but you will not have the very specific organ failures that may be involved when your physician documents multiple organ failure. And one of the other things, we still going to have a code. SIRS is going to change a little bit, that terminology, SIRS. And I won't have time to get into that today, but just know that your 99591 code will go away in ICD-10, okay? But I'm sure some of you all know that if you've taken some training. Another documentation tip they talked about was meningitis. Well, currently in ICD-9, meningitis is coded by whether it's bacterial or is it viral. That's not going to change in ICD-10. Of course, once again, if it's a bacteria, you would like for the physician to document what the bacteria is. However, they may not be able to culture anything. You know, as coders, and maybe you're new to coding, and as a CDI specialist, clinical documentation improvement specialist, it's our job to review the medical record and look at the documentation. You know, if you go to the lab and all the cultures are negative, there's nothing to query the physician about. They negative. So for me, Michael, I think it's important that we as coders, we don't want to look stupid to the physician. We want to appear intelligent. Don't ask the physician for something when there's clearly no evidence of it in the chart. Now, if you went to the culture and saw E. coli, now you got a reason to ask them.
Well, that goes back to what you like to say. Coders get paid to think. Look at the documentation. If there's nothing there, why are you going to ask?
Thank you, Michael. I really agree with that. We're going to get ready to take a short break, and when we come back, we're going to talk about the ASPEN criteria. Hi, welcome back. We was talking about viral infections or sepsis when we left. Michael is going to talk with us a little bit about malnutrition, and I may chime in. I'm Mary, and it's hard for me just to sit here and be quiet. So, Michael?
One of the more prevalent diagnoses that we're seeing as coders is malnutrition. Now, if you're a new coder, 3M gives you some options on malnutrition, but a lot of times you may not have the information you need to support a severe malnutrition. You may just have the physician list malnutrition, and you may have a body mass index. Mm-hmm. Not a lot of information to work with. Malnutrition is becoming a very prevalent topic in coding today. There are some criteria that we can, as coders, become knowledgeable about, and it's called the ASPEN criteria, and I will just tell you, if you want some more information to this, Google ASPEN for malnutrition, and it will take you to a journal article that will give you more in-depth. But basically, it gives a set of criteria, including insufficient energy intakes, weight loss, muscle mass loss, fluid accumulation, subcutaneous fat loss, and diminished functional status. All these things tie into the type of malnutrition as well as the degree of malnutrition. And if you end up as a coder having to query the physician, you can refer to this and let the physician then review the criteria and further clarify the diagnosis if that's what they see fit.
That is true, Michael. One of the statements that Michael made was that we see malnutrition documented more now. I recently did a webinar on malnutrition, and in my study for malnutrition, it talked about the fact that it's been a diagnosis that has been missed. Many physicians miss that diagnosis. And so as coders, physicians are going through a lot of training to be able to recognize the signs of malnutrition. And so we'll see it more often. In ICD-9 as well as ICD-10, you'll be able to code the severity level of that malnutrition. And once again, the ASPEN criteria help us as coders to know when to query for that severity level, whether it's moderate, whether it's severe, levels that are involved. Now, of course, you the coder, you'll have the chart, and you may not see any evidence of a more severe level that you could code. But if it's documented, your muscle weighting, the muscle wasting that the patient may have, seeing how the patient have a decreased energy level, all that may lead to you querying for a greater specificity of that malnutrition. The other thing that when I did my research on this, in America, we eat a lot of calories, but they are not necessarily nutritional calories. And because of that, that was one reason why sometimes that is a misdiagnosed condition, because this is where the patient is eating. Yes, the patient may be eating calories, but maybe not nutritional calories. We also, in looking at that, doing the research for the malnutrition, we talked about the type of people that we may see that are malnourished. Demented patient, somebody that has dementia, could be prone to malnutrition. They forget to eat, or they don't eat enough. And so sometimes you have a malnutrition in your demented patients. Alcoholic patient is another type of patient where you may see malnutrition. So it's malnutrition is a big problem even in America, but because we eat a lot of calories, we don't think about it being a problem. And as coders, sometimes we are looking in our chart to try to find why a more supporting diagnosis, if that makes sense to you, to support. Why is this patient in the hospital so long? So when you're looking at malnutrition, you're looking at weight, you're looking at definitely weight loss, you're looking at definitely a lower BMI. You could be looking at someone that does have muscle wasting. You're going to be looking in your orders to see how was this patient treated. Was protein shakes ordered? Was there a nutritional consult ordered on the patient to help support that the patient was treated for that condition? So that was what we wanted to talk about today. So we gave you a little bit of information today about infections. We talked about malnutrition. And I just want you all to be very aware of making sure that your documentation always support whatever you code. And I think that's, do we have any other questions that we have? I think I cleared up the question that we had about the XU modifier. We talked about the importance of you following your coding guidelines, knowing, you're not going to remember every coding guideline. But I always like to train coders or teach coders, you should have some type of internal bell within you. You should have some type of internal warning that, I saw something in a guideline about that. Maybe I need to look it up. And always remember, ultimately, you are responsible for your coding. We have to accept that responsibility. If we put bad data in, we're going to get bad data out. But I also realize that you can only code as accurately as the documentation will allow you to. So it always goes back to documentation. And I think that as we move into ICD-10 with the specificity of the codes that we have really got to help our physicians understand that. I also believe quite strongly that we probably have enough documentation in our current record to support some of the acuity levels or specificity that we may see. For instance, sometime I will see a physician documenting that the patient has moderate persistent asthma. But see, in ICD-9, you can't code moderate persistent asthma. But when we move to ICD-10, you can. So there's documentation that's in the chart currently. I think that can help us to have a smooth transition from I-9 to I-10. It's just going to take a little bit of work, I think, and acceptance that as we move to this. I think that so many people are just going to 10 that, Michael, that they tell all the horror stories. They don't tell any of the good stuff about 10. So we want to thank you for tuning in today. And I want to encourage you all to follow us on Twitter, Facebook, and LinkedIn. Also, subscribe to our YouTube site. We would love it if you would become a subscriber. That would just make my day. And always remember, on our website, www.mascodingsolutions.com, we have a little box at the bottom that says Ask Mary, so you can send your questions in to me. And thank you for subscribing, and thank you for reviewing today, and we'll see you soon.